Okay, I think we are about to go live in the next 5 seconds or 7 seconds.
We are live. We are live. So I will
Yeah,
start
we are
off.
live.
Yeah. Good evening, everyone.
Yeah, please.
This is another session on reproductive immunology and recurrent pregnancy loss and recurrent miscarriages. So this topic is on genetics, which I think is Greek and Latin to majority of us gynecologists, and we want the practical implications of the genetics on RPL and RM to be spoken about, and not about much about the DNA, RNA, and all that stuff, which is a little difficult to understand. So today we stick to only clinical aspects and how it is relevant as practitioners for us in dealing with cases that we come across in our day-to-day practice. So I request everyone to watch the previous 7, 8 sessions on reproductive immunology, which will give you a much better perspective about how to deal with this whole condition in a more, I think, scientific way. So today's class is purely on genetics. Over to you, sir. You can take over.
Shilpa madam, please stay unmuted because I'll be sharing the screen and I'm on the highway. So, right. So can you see my screen?
Yes, yes.
Okay. Okay, fine. See, whenever we are talking of genetic abnormalities, no, we always have this huge issue in trying to pick up what exactly we need to understand when it comes to recurrent pregnancy loss or recurrent implantation failure. All right. So please understand this basic concept. Whenever you are taking an oocyte, the oocyte has a nucleus inside that. The other part of the nucleus, we think it is diploid, but it is actually haploid. Nahi? The other part, the other remnant of that is the polar body, which contains 50% of the genes. All right. And then you have the poor sperm here. The sperm, any which ways, has only 50%. There is no polar body in the sperm. What happens is when you do ICSI or whenever there is fertilization, forget ICSI, whenever there is fertilization inside this, the middle piece and the tail are going to stay out from the zona. Okay. And only the DNA of the sperm, which is located in the sperm head. Okay. So let me draw the sperm's DNA in a green color. Okay. This is going to go inside. So now one haploid. See, these two people are going to join together to form a diploid body. This diploid body, okay, what you try to check when you try to check the diploidy, basically, is when you are trying to check for the fertilization, the pre-fertilization check, what we try to call something as the pronuclei. Okay, we always try to check this. All right, so whenever you see two of these pronuclei, you are very confident that, okay, it is a diploid fertilization, and in a diploid fertilization, when division occurs, so when this guy divides into two parts, okay, now it is divided into two diploid cells. Okay, after fertilization, the blastomeres which are formed are everything diploid because it is mitosis. When the egg is formed, it is arrested in meiosis. How the sperm is formed? It is a meiotic division. After fertilization, all divisions will occur are mitotic divisions. That means there is no reduction in the number of chromosomes. There is only doubling of the cells. All right, just keep that in mind because this is forming the basis of all these things. Okay. Okay. Now, let me just take one more minute to explain something more scientifically. Okay. We think, see, let's assume this is 23x. Let's assume this is also 23x. Okay. Why am I saying 23x, 20x is because you are going to have 22 autosomes basically. Okay. And one sex chromosome. You're going to have 22 autosomes and one sex chromosome. This is in the ovum and this is in the sperm. Correct. Now, when both of them are going to join each other, it is going to form 22 pairs of autosomes and one pair of sex chromosome, which we call as 46XX. Correct? No? That is what it is going to form. So how does this actually form? This is important. Let me just analyze one chromosome for you. Let's assume this is one chromosome. Okay, we understand this, no? Okay, if we don't understand this, I will explain this also because this is also another very important part you should understand. Let's assume this is from the female male part. What is this called? This. Okay. Now you see that the arms are equal in length. Okay, when the arms are equal in length, it is actually not like that. Okay, in all the chromosomes which you see, one arm is going to be the short arm, one arm is going to be the long arm. Why am I calling short arm as P? It is a French word. It's called petite. Petite means short. For Q in French, which says long. So maybe after P, the next word is Q. That is why those idiots thought that okay, you can call it Q. Okay, so P is always going to be the petite arm or the short arm. This is your nomenclature. Q is always going to be the long arm. Okay, in the human body, no, majority of these chromosomes, no, are something where the arms are almost equal in length. Okay, these two arms are almost equal. What is it called? You know, this is called as meta. Meta is Facebook. Metacentric. Metacentric means arms are almost equal in length. Okay. Second, which is very common in the human body, is acrocentric. What is acro? Acro means head. So that means the centriole, na? And for an acrocentric chromosome is something like this. Okay, like this. It is located at the very top, very short arm, which is the P arm, and a very long Q arm. Okay, very long arm and a very short small arm. Okay, so just keep this in mind. Why am I telling all this nonsense? Because we commonly see reports like this, no? 21QHS, and we are horribly confused. Why 21? Why Q? Why H? Why S? I don't know anything. I will counsel and I will speak to my genetic counselor. That is wrong. Okay. Please remember, two simple things happen inside all of this. Okay. Before you understand all of this, because before you go to the abnormalities, no, just understand how this mix match occurs. How God has designed this entire mix match to occur. Let's assume this is male, this is female chromosome. Okay. Now, both these people have to go and join to each other. Okay. It's not so simple also in life. You know, nothing is so simple. So it is not going to be that, acha, acha, chalo, aao gale milo. You know, they will be like 50-50 karte hain. Nothing like that happens in life actually. Some chromosomes, some segment from here will go here, some from here will come here, some from here will go here, some from here will go here. You know, this type of things keep on happening, keep on happening, keep on happening in the body. Okay, that is why there is so much genetic rearrangement which keeps on happening. I don't look exactly like my dad. My daughter does not look exactly like her mother. Correct. That is because of so much of crisscross arrangements which happen even in the time of division. So it will happen even in the time of meiosis, and the same variations might happen in mitosis also. Okay, but where does the problem come? Let's assume both of these are autosomes which were to form chromosome number 1. Okay, problem happens when instead of 1 it goes and gets attached to 21. Okay, this when you know when there is separation occurring, no, inside the egg, what typically happens just at the time of fertilization, no, God will develop two centrioles, ek idhar, and the chromosomes which have come in the center, na, all the chromosomes, God will pull all these chromosomes, aadhe idhar jao types. Okay, and when these guys are getting separated away from each other, sometimes the bonding between the chromosomes is so strong that three will go together. Okay, sometimes the translocation will occur. One ki jagah pe, instead of going and getting fixed to chromosome number 1, it will say, "Arey nahi, you know, I found chromosome 11 slightly more sexier, so I will go to chromosome number 11 and go and get attached there." You know, simultaneously 11 ka ek part will come to 1. It is called as balanced translocation. Okay, whenever there is balanced translocation, no, just remember one thing. Balanced translocation, you will always get two values. Okay, that for example, 11 ka P got fused with 12 ka Q. Okay, and uske pehle they will tell you this is the translocation. This is the sign on how they will represent it in the genetic report. So don't get confused. T is for translocation. P means short arm of chromosome 11 got translocated with long arm of chromosome number 12. Understanding? Now, there is also something called as unbalanced. Unbalanced matlab kya? Okay. It resulted in formation of trisomy. What is trisomy? Instead of going to a particular chromosome, all three went together to chromosome number 21. That was not required at all in life, but that happened. Hai na? So how do you understand all these things, all this, Greek and Latin, which I right now spoke? How do you understand this? You see those beautiful reports of the chromosomes which you get now, G banding. Okay, there is something called as G banding. All the blood report, no? See, as clinicians, we don't look into it so much. But see, we get a report like this, na? Nice report. Chromosome 1, chromosome 2, chromosome 3, okay, chromosome number 4, you will have chromosome number 5, then you will have chromosome number 6, then 7. Our reports gives us these images, no? And in India, we don't get the report for the sex chromosome. We don't get the report for that, correct? So you get this beautiful report, no? This is basically something called as karyotyping through G banding. Okay, so it is a technique in which the helices, the free ends get picked up, and you are going to be able to map this. How do you map it? You just take blood. Okay, so that is why we give a blood sample for doing this. In the blood sample, you isolate the T cells. You break the T cells into multiple pieces so that the DNA comes out. That is because T cells are the easiest and the most stable. Okay, so the DNA comes out, and then you amplify this DNA. Once you amplify this DNA, you subject it to G banding. And once you subject it to G banding, you look at it inside the machine and you report it. All right. So this is a big technique. This reporting is done currently by a human, and it is also added by AI. That is why you require a geneticist to report on the karyotyping report, because a geneticist would look at a G banding pattern and he would understand, is there a translocation? Is there a deletion? All these bhari words they use now. Translocation. Okay, deletion. Okay, deletion means what? One particular gene got deleted. Okay, that is what is important from all these things. Translocation means ये इधर का इधर चला गया. Balanced translocation means इधर का तो इधर गया पर इधर का भी इधर गया. Understanding? So all these reports you are going to get when you try to study genetic abnormalities. Okay, you studied all these things. Very good. When you study a couple's report like this, okay, when you have a couple who has reported as, let's say, shortening, so chromosome number 21 pe, on the long arm, that is Q, okay, there is one particular segment, short HS. Okay, I'm just putting something, okay. It could be, it's not the exact depiction, but something has been shortened. Okay, now you will have a report which will tell you, acha, but this is shortened, non-significant. Okay, karyotyping report is normal, but this is a non-significant finding. In a non-significant finding, what do? In a non-significant finding, you may tell the patient sab kuch normal hai. The patient will Google. And when the patient will Google, patient will tell you, Arey madam, this can be the reason for having infertility. Okay, please remember, lot of the chromosomes have lot of areas which are buffer areas. Buffer areas means there are no genes which are going to be depicted through that segment of the chromosome. So even if that segment is shortened, it is not going to cause any genetic abnormality to the patient, which is why they say there is non-significant inside it. Understanding? And if it is not going to cause any genetic abnormality, the patient does not require to go through any form of PGTA, nor does the patient need to go through any form of genetic counseling. Understanding? Of course, the patient will also get mapped for particular genes. For example, somebody has an autosomal recessive Duchenne muscular dystrophy. Somebody has thalassemia minor. Somebody has thalassemia major. Somebody has whatever, whatever that is genetically linked. Okay, if that is being reported in any of your karyotyping report, that, okay, this report seems to have this particular problem. Like, for example, a common report which we get these days when somebody has come with low AMH, or when somebody has come with a premature ovarian failure, that is Fragile X syndrome. Correct? What do you get to know about Fragile X syndrome? How do you treat this patient? Again, more common, Turner XO, only one sex chromosome is present. Turner mosaic, it is XO, and some of the T cells which took out from there gave rise to XX also. Correct? All this helps you in genetic counseling. Please understand these things. Okay. Now, after, I don't want to discuss more than this as far as understanding of these genes and sorting out is concerned, because if I discuss, then most probably Shilpa madam will catch a flight from Bangalore to Hyderabad and she will shoot me in the center of my head. So let me come to the clinical applications of all these things. Okay. How do you apply all this clinically? Now this you understood. So next time you see a report like this, first go through this masterclass. You will easily understand. When you speak to the geneticist next time, no, you will only ask, Bindas. Arey bhai, it is written short arm mein deletion hai. What is the matlab? That geneticist will stand up and salute you. Oh, thank you, madam. So, you gave such a beautiful answer. First point only, full marks. Like that. Okay. Significant is only one thing. For recurrent abortions, if the embryo is aneuploid, you have to be very happy that God destroyed a bad embryo, did not allow that embryo to grow. Simple. Okay, no further evaluation needed. If it is a euploid embryo, that means embryo mein everything was fine, genetic arrangement was good, still it aborted. That means there is a cause in the female partner which caused this particular abortion to happen. Okay, this is your relation to abortions. Your relation to IVF. If the couple has a known genetic defect, it's amazing that you can do something called as pre-PGTA. That means you can send the couple's blood for analysis before doing the PGTA. That is usually seen with something called as whole gene exome sequencing. Whole gene exome sequencing is again very easy. You don't have to apply your head. Blood में से ही किया जाता है. It is a blood test only. No nose, buccal, mucosa, all that nonsense is not done. Simple blood test is done. In that blood test, they will identify significant genomic areas which have been mapped for a particular country. Understanding through a significant correlation with the gene bank. Understanding, they will map that and they will tell you, okay, you have pathognomonic features of, let's say, retinopathy. You also have pathognomonic features of, let's say, Duchenne muscular dystrophy. And you also have pathognomonic features of osteomalacia. Correct? They will give you a report like that. Is that gene expressing itself or not expressing itself? That is when it comes to autosomal. That means on the autosomes, one of those 22 other chromosomes. Okay. If it is recessive, that means it is present, but it is not 100% active. If it is dominant, that means even if it get exchanged, the possibility that it will express itself is 25%. Understanding? If it is recessive, that means there is no jhanjat only. The female partner also should be recessive. Male partner also should have the recessive problem. And then the expression is going to be 25% in the child. So that is very easy. Okay. In Y-linked chromosomal problems, jo embryo mein Y-link hai, if it is a male embryo, it will have a problem. Simple. For example, AZFA, AZFB, AZFC, these are Y-linked chromosomal disorders. If your embryo is a male embryo, the embryo will 100% have it because your Y, you can't genetic engineer or do a laparoscopic surgery on the gene and cut off that with the laparoscopic shearer and say, je normal ho gaya gene, jao. Like that does not happen. Understanding that editing is something called as CRISPR, which is currently only allowed in China, not allowed in India. Understanding? So that is 100% transmissible. That is why for any sex chromosomal defect, you have to 100% do PGTA to ensure that the embryo does not carry that gene. Understanding? For autosomal recessive, you can be really chilled out and relaxed. Autosomal dominant, you should do because autosomal dominant has a very strong inheritance pattern and you should do it. There are many more things to this, guys, like how an autosomal dominant gene expresses itself, how much percentage it is effective. Correct? That is also very important. How much percentage is the autosomal recessive gene important? I mean, how much it is expressive? That is also very important. We'll come to the expressions later because the expressions are not just mediated by the genes. Expressions are mediated by genetic factors as well as epigenetic factors. So maybe one day we'll take a class on epigenetics. Okay, and we'll discuss how a particular gene can express itself in a particular environment. Understanding? We'll come to that as we advance, if Shilpa madam allows us to advance in this genetic curriculum. Okay, fine. Now comes the question, what should you as a clinician advise to the couple? Should you advise karyotyping of the couple? Should you advise whole gene exome sequencing? Correct? Remember, if you are screening a couple and suspicious 2 abortions have happened and you want to screen the couple, okay, very easy, advise only karyotype. Okay, but if the couple is telling you that my previous baby had glycogen storage disease and baby passed away, my previous baby had multiple cardiac anomalies and my baby passed away, correct, cause is not known. In that situation, POC karyotyping was not done that time. Bhul gaye. Madam said no, Shilpa madam said no, that the kit was not available. Correct. So aise pakad ke chalo, in that POC karyotyping kit was not available. So there is no data available for that. Correct. So in that situation, you can consider to do whole gene exome sequencing. But remember one thing, whole gene exome sequencing is a costly test. For the couple, it is going to cost you approximately 55 to 60,000 rupees. Okay, compared to karyotyping, which will cost you around 6 to 8,000 rupees. So please have this in your mental makeup and then you start testing. Majority of the karyotyping, the routine karyotyping which you do is going to be reported on GBATing. Don't worry about all these things. One question which people will ask, what is fish? This fish is different than the fish which we eat. Okay, that is the first thing. This fish stands for fluorescent in situ hybridization. Means you have a probe available which will light up when it picks up a particular number of chromosomes. Okay, that is important. If the fish 5 probe has been activated for 5 probes, that means try number 13, number 18, number 21, X chromosome and Y chromosome. Understanding? Or if it is a fish 3 probe, that means 13, 18 and 21. Those genes, it will go and tag itself to those chromosomes in a particular manner. That if there are 2, it will show you 2 blue, 2 green, 2 red. That means trisomy is not there for 13, not there for 18, not there for 21. The commonest question which people ask is, अरे it is trisomy 3 क्यों नहीं दिखा? अरे normal है, 3 होता तो abnormal report आएगा ना. If it is trisomy 21, you will see 2 green, 2 red, but 3 blue. Understanding? So that is how fish is. Fish is a very fast test. Fish does not really require any processing. It can be done by people like us also. It does not really require any advanced genetic material, genetic stuff, nothing it requires. You just need a standard genetic analyzer for reporting fish. Okay. Uske upar, then people get confused between two things. A little show off, when it comes microarray versus NGS. Okay. Microarray and NGS are simply platforms. Okay. It is like तेरे को तेरा मोबाइल एंड्रॉइड पे चलाने का है, iOS पे चलाने का है. Simple. These are platforms in which you can sequence the genes. Obviously, because now the cost for NGS has gone down. What is NGS? It is next generation sequencing. ठीक है? Next generation काय को? Because the previous generation was microarray based. What is microarray? Microarray matlab chromosomes are divided into particular trays, and the chromosomes will go and match those trays. Based on that, you get a detailed analysis. But now that is gone out of vogue. Now the thing which has come in is NGS across the world. As more and more things and theories advance, even our embryos, PGTAs is being done on NGS. Even non-invasive embryo biopsies. I mean, even non-invasive, chromosomal studies called as NICS. Okay, that is also done on NGS now. So if you don't know anything and if you want to show off, you tell people that I think it has been done on NGS. 99% of the times you'll be right on. Because now, because of the availability of kits, NGS is the platform of choice, not just for humans. Pig, cow, donkey, anybody you take, everybody's genes can be analyzed on NGS. Okay. I hope in this much, my time is also up actually, but I hope in this much we have given clarity on the basics of genetics which everybody needs to know for reproductive medicine as well as for abortions. Okay. Shilpa madam can maximum ask 2 questions and then we can call it quits.
This is basic. This is PhD level. Okay, listen. So there are 4 things. One is translocation. The other one is inversion, deletion, mosaicism. 90% of what you told, I didn't understand only. I'm so sorry. So much you are telling in 10 minutes. This is supposed to be spoken for 1 hour. And you are squeezing everything in this 10 minutes. How do we understand as general gynecologist if you are telling so much stuff in 10 minutes? We have to keep it at 0.2 speed and watch it.
Okay, listen. Translocation, I already told you, madam.
Yeah.
Instead of getting attached to chromosome number 1, it went and got attached to chromosome number 9. That is translocation. Okay. And the part which was going and get attached to chromosome 9, it came to part chromosome 1. So there is a translocation between chromosome 1 and chromosome 9. That is translocation. Correct. Inversion, matlab, it was supposed to get attached like this, like a dandi. Okay. It went and got attached ulta. Okay. That is inversion. How it changes the genetic makeup is one protein which that particular straight dandi would secrete when it goes and gets attached inverted. That protein synthesis may not occur because the structure of the protein will change. Understanding? Or the structure of that molecule will change. Let us just put it that way. Okay. And because it changes, it can cause storage disorders. It can cause, anatomical defects, pigmentation disorders and all these things. So that is your inversion. Deletion, matlab deletion. It is not present only. Okay. Lost in transit. अपना बैग कैसे एयरपोर्ट पे घूम जाता है, like that. in that entire transit, that particular region of the gene got deleted. साफ हो गया. All the proteins which it was supposed to secrete. मान के चलो, it is supposed to secrete proteins to ensure that hemoglobin stays nice. That proteins it is not able to secrete now. है ना? So that is the problem of having deletion. बराबर? Mosaicism का मतलब, see what is mosaic? Okay, mosaic means आधा ये साइड का है, आधा वो साइड का है. कौन से साइड का है मालूम नहीं पड़ रहा है. Understanding? That is the meaning of. Don't laugh, Shilpa madam. That is the.
Sorry.
That is the meaning of. Array?
Who will explain like that? You should tell it scientifically.
Oh, but this is the best way to understand. Last 10 minutes I was speaking science. You said you did not understand anything. Now I'm not speaking science. You are saying speak science. What is this?
Sorry.
Yeah. So mosaicism is basically you don't know the genetic origin. Correct. You don't know if it is belonging to a particular genotype or it is belonging to some other genotype because the rearrangement is yet to occur. You know, the best example of mosaicism is when you do chorion-villus sampling. When you do chorion-villus sampling, see, why is it that we say don't do chorion-villus sampling before 9 weeks? Because it causes too much mosaicism, no? Why? Why? Because that syncytial trophoblast you have biopsied or you have biopsied the maternal cells you don't know, which is why there is mosaicism. Understanding? As placenta matures, the integrity of maternal and fetal is so strong to each other and it is so cross-linked that if you biopsy a placenta at 20 weeks, it will be mosaic. You will not know if it is maternal side or fetal side. Understanding?
Okay. So tell me, this nomenclature of aneuploidy is just about the numbers, is it? I mean, is it about only the trisomy and is it only the monosomy?
Monosomy, trisomy, all these things.
Yeah. And deletions, do you see it more commonly in single gene defects, which has been like, hyped so much, which can, so how do you detect the single gene defects? When we counsel,
Best to detect single gene defects is NGS, madam. Best.
No, that is like 99% of the times that is the answer you only told, NGS. But what is that NGS? I mean, how do we differentiate? See, when you want to diagnose a single gene defect, so you ask for what test? You can't just say NGS. NGS is everything, right?
No, you ask for whole gene exome sequencing.
Yes.
Whole gene
So
exome
whole gene
sequencing.
Correct. So whole gene exome sequencing is the only answer for single gene defects.
Absolutely.
And that is what has to be done to detect single gene defects. So
correct.
Yeah, in G banding, like how you said the chromosomes, in this we get only about the numbers, as in if there is
some amount of numbers and shape also. So you will identify deletion, inversion as well with an experienced geneticist on gross defects. It is only good to identify gross defects of these things.
So, but is that an objective thing or a subjective thing? Like the geneticist looks at the reports and then reports it, or is it like just like a cell analyzer?
No. The geneticist will look at the pattern of the banding.
Okay. And see, if there is one test you want to suggest for ruling out these genetic problems, if the couple come like without pregnancy and previous, like, one blighted ovum, one missed abortion, one anomalous baby in 5th month, and then probably one IUD at 8th month, something like that. So would you tell them to just go for whole gene exome sequencing and do it there? What is your...
No. I start always with karyotyping. If the karyotyping is normal, okay, then there will be detailed evaluation if there is consanguinity in the marriage or not. Then there will be evaluation if there is any expressive disorder in the parents, siblings or whatever. And if all that is negative, then just karyotyping of the couple is more than enough, madam. Okay. Whole exome sequencing is important when you have something which you have strongly suspected. Please remember that. You can't do whole gene exome sequencing on things where the suspicion quotient is very minimum, madam.
No, but how do you suspect? I mean, do you think, morphology or like, is there anything that you make the concern?
Previous history. For example, previous history of IUFD you told. IUFD can occur due to a lot of things. But if it is a previous neonatal demise which has occurred when the child went into respiratory distress, or, the child had some expression on the skin, or there was a anomalous face, okay, or something like this, no? In that situation, you must counsel for whole. I will take a master class on this. When should you do whole gene exome sequencing? When should you do just karyotyping?
Yeah, that is
Promise.
important, I think now. Okay, tell about this balance translocation. You see a patient where one of the, among the couple, one of them has balance translocation. And what do you advise? Do you
PGT.
advise PGTA, and what is the
Yeah.
risk? Is it like 25% risk of the embryo? Anything
It
at all?
depends. No. It depends. You see, when you have a balanced translocation, remember, the translocation can rebalance in a manner where 9 can again go and get stuck to 9 only.
Yes.
And 11 can come back and get stuck to 11.
Yeah.
Okay, so for practical purposes, the risk is 50-50. But for scientific purposes, the advice has to be to give the patient an option of doing PGTA.
Okay, so in this PGTA, what all you can do? See, what is the difference between this PGTA and PGTM that
That's a master class. No, that's a master class.
Okay,
M is
so
for M is for mono gene defects. I'll come to that.
So in PGTA, like what is the one main indication for this PGTA in your practice?
Previous 2 or more failed IVF cycles where no previous PGTA testing has been done. Okay, with a normal history for the patient. Otherwise, any suspected genetic cause in the patient, PGTA is a must. Absolute must. Okay.
Okay. And so you said like you do the for suspected Turners or fragile eggs, what is the ideal test?
Karyotyping. Standard karyotyping.
Standard karyotyping will find it out. Okay. And for standard karyotyping, is there any particular way that we need to send the blood sample, or is it just a regular blood? We just send it.
We just have to send the blood. They will lyse it.
Okay. And this gene expressions which you were talking about, that it is recessive and dominant and all that. So
Yeah.
the commonest, like I think both of them, we see it quite equally, the recessive
Both are equally seen, madam. Absolutely.
and so this X-linked and Y-linked, I mean, is it legal in India to identify and
They will report it is an anomalous gene.
Okay.
But they will not tell you that it is anomalous X gene. Something like that.
Okay. Yeah, I think that is all I understood. Okay, so how much does the fish cost? Do you do always fish before you do actual the karyotyping if on an amniocentesis or a CVS?
No, so nowadays we are doing fish only when the suspicion for a particular trisomy is very high. Otherwise, we do microarray only, no, madam, for the amnio samples.
Yeah. Okay, in your practice, because you have been doing so much of evaluations and PGTA, PGTS, and run a reproductive immunology department also in your unit. So, what is the commonest genetic problem that you have come across? Is it like Duchenne's muscular thalassemia? Okay.
Yeah.
What about sickle cell?
Not so common. Thalassemia is the most commonest because because I am a Gujarati, so I end up treating a lot of Gujaratis, Kachis, Sindhis and all. And in that community, thalassemia is common.
Okay. And do you do like the gene identification for that and check it out? What do you do in thalassemia when we talk about thalassemia?
So it depends, madam. If the couple is both thalassemia minor, then you need to find out what is the gene expression for thalassemia minor. Because thalassemia is a very big genetic condition, no? Then you need to do PGTM because you need to make a probe for that particular expressive gene in that individual couple. Okay. And then the embryo needs to be classified as a thalassemia-free embryo. And that embryo is put back inside the mother.
Okay. Do you have a full-time geneticist in your hospital, or your role is also geneticist in your hospital?
Am I supposed to answer that question or that's a rhetoric?
No, that is just a statement. That was not a question. Okay, so you tell us, like, if the embryo is arrested between day three embryo arrest and blastocyst arrest, like if it doesn't even reach day 3, so what is your probable, like, I mean, genetic cause you would think of, or media, or this thing between day 3 and blast?
No, See, when there is a persistent arrest 2 or 3 times between day 3 going to day 5, that is the time when the genomic shift occurs at the level of morulation.
Yeah.
That is when the embryo begins to, there is a genomic shift. Rather than being dependent just on the maternal genes, it starts to develop its own genes, so that the media which is surrounding that particular embryo, it can, take certain take certain factors inside and proliferate further. That is something called as embryonic shift or embryonic genomic shift. Correct. Now, if that has not occurred, that could be multiple reasons. Age being the most commonest factor of the female partner. Correct. Age of the female partner, most common. Second most common comes your culture conditions. Okay. I don't think we should think of genetic causes in that, madam.
Okay. Yeah. That is just to tell that, I mean, it is not about the genetic cause in such situations. It is more about the maternal age. Yeah. So I think for now we are okay. So we'll have to do
I
another
have a
class.
question, a very, very simple question. And this question stems from the fact that I have seen patients who've had a karyotype test done in the past, and many a times I see the geneticist say there is an abnormal report which is given, and we send this report to the geneticist, and the geneticist says, no, I'm not satisfied with this report. I need a repeat karyotype.
Yeah.
And what I have noticed is the geneticist wants to see a report with the entire picture,
image. They want to see the entire framework on the tray as to how the magnification quotient for that particular genetic makeup is. And that is why I said the role of the human, the geneticist is very important in reporting the G banding.
So that is an important take home, that when you are advising a karyotype, it needs to be done in a lab where you are having that image of the,
reference image.
Yes, the reference image of all the chromosomes. Because that is what they want to see, because sometimes they are not convinced about the abnormality which is being reported.
Yeah. I think we are good for now, but we still have to discuss this in another class. It's okay. We'll just have a Q&A session for reproductive immunology sessions, if that is okay with you sometime.
Okay, boss. Whatever you say.
Thank you. Thank you,